item, which, as we both, Marcia and myself mentioned, it is going to be an action item. And at the conclusion of the presentation, after we hear from board members, we will invite the public to speak if they wish to do so. And then we will take action on this item. So with that, Ms. Green, are you ready to go?
Marta, you're coming online right now. There you go.
Great. Thank you, Mr. President. Good morning, and members of the board. Marta Green, CalPERS team member. Can everyone hear me?
Yes.
Great. Thank you. Before we get into the presentation, I want to share a development that could possibly positively impact our members in Monterey County. As we have discussed previously, we've been working with Blue Shield of California to expand its Trio ACO product to areas of California that do not have access to a lower cost, high value HMO. We are pleased that the board approved Trio's expansion into Santa Barbara, San Luis Obispo, and Ventura counties for the 2021 plan year. Fortunately, Blue Shield has had further productive conversations with providers in Monterey County, and it may be possible to expand there in 2021 as well. This would be especially helpful in Monterey as it would provide a low premium option via an ACO arrangement in a very high cost county. ACOs are good options for members because they can provide better coordination of care than fee-for-service arrangements and can guide members to appropriate sites of care. This expansion is aligned with CalPERS' strategic initiative to increase healthcare competition in low competition areas. However, there are multiple hurdles that still need to be overcome to bring this product forward for 2021. These include securing contracts with the necessary providers in Monterey County and gaining regulatory approval of the service area expansion. And the timeline for both is very aggressive. These hurdles would need to be resolved before the September board meeting so that we could bring the expansion to the board for approval then. Again, this is just a potential development, but it would be a positive one for our members. And unless there are any questions regarding this new development, I can jump straight into the presentation.
I see no questions on the screen. Proceed.
Great, thank you. So as the president and our CEO said, this is an action item for your approval. The final proposed premiums have been provided to you in a separate document and are available on the CalPERS website. Attachment 1 is for HMOs and attachment 2 is for PPOs. Both give single party, two party, and family premiums for the state and contracting agencies and schools employees by region. Next slide, please. Today, I'll briefly recap our journey through the premium setting process this year. As we have discussed, there have been significant changes to our process and some challenges created by the COVID-19 pandemic. I'll go through the statewide average rate increases for 2021 and highlight some plan-specific rate changes since June. Then we'll conclude with next steps. Next slide, please. There have been significant improvements to the rate development process this year. The team developed a baseline rate for the 2021 plan year and to put CalPERS in a stronger negotiating position. In addition, we standardized the methodology on medical cost projections across all plans, which improved our ability to identify the cost drivers, as well as to compare medical utilization and unit cost trends across plans and against our own assumptions. We extended our timeline to allow for more information about the pandemic to inform our decisions. The 1-month delay in our rate setting calendar gave CalPERS, our contracted health plans, and our actuarial firms time to more accurately model the impact of the pandemic on our portfolio. We have applied healthcare fund adjustments based on our healthcare fund reserve policy with some modifications due to the COVID-19 pandemic. Because of the delayed and deferred care in the 2020 plan year, the reserve balances in our fund are increasing slightly. As a result, for some plans, we propose using 80% of the sub-account surpluses to offset costs related to COVID-19 for the 2021 plan year. In addition, we recommended varying slightly from our PPO reserve policy to use anticipated savings to also offset costs in 2021. In June, the board approved several changes for 2021 for the basic and Medicare plans, including the service area expansion for Blue Shield Trio that I already discussed, and also the new Sharp Medicare Advantage plan in San Diego County. We added some exciting new benefits for Kaiser and United Healthcare Medicare Advantage plans to keep members healthy and out of the hospital. And lastly, Anthem Medicare Advantage plan will provide an option for members in Anthem Select HMO Basic to stay in their network when one of their Medicare eligible family members puts them in a combination tier plan. Additionally, as a result of the economic crisis we now face and the state worker furloughs, Several of our carriers are willing to reduce their administrative fees or make other concessions for 2021 to help offset the cutbacks that our members are facing next year. As we shared in June, Blue Shield reduced Trio's medical rate by an additional 2%, leading to a modest premium increase of 3.07%. Additionally, Sharp, United, and Western Health Advantage are also reducing their administrative fees to help our members during this pandemic. Next slide, please. The overall change in the final proposed 2021 premium, especially given the significant uncertainty created by the COVID-19 pandemic, is modest. For basic HMO plans, we see a 4.44% increase in the weighted average, which is slightly decreased since June. This is mainly driven by the provider contract improvement and administrative fee reductions for United Healthcare, and I'll talk more in detail about these in a moment, and the administrative service fee reduction for Sharp and Western Health Advantage. Our PPO plans are unchanged since June and show an increase of 8.54%. Our HMO Medicare Advantage members will see a reduction in premium, even with the increase in benefits that were approved in June. On average, the 2021 premium will decrease by 4.46% from 2020. The difference between June and July is due to the updated CMS revenue projections from Anthem's Medicare Advantage plan, which I'll show you on those plan specific slides in a moment. The PPO Medicare supplemental plans are unchanged since June and have an average decrease of 0.65%. With that, our total weighted average change from 2020 has improved since June and is now at 4.32%. The total weighted average, just as a note, does not include the association plans. Next slide, please. Premiums for preliminary 2021 premiums were provided to the board in June, and since then, our team has continued to monitor claims and finalize administrative service fee negotiations with health plan carriers due to the reduction in state worker pay. Today, we will only review those plans with rates that have changed since June. Next slide, please. For Sharp, the changes from June and July are attributed to adjustments to the administrative services fees. Sharp has offered to reduce their ASF in light of the governor's budget, and the administrative services fees for the remainder of the 2020 calendar year will be reduced to the 2019 level. We use these savings to slightly reduce the 2021 premium. This brought Sharp's overall increase from 4.44 to 4.33%. Next slide, please. The decrease in United Healthcare's premium was primarily driven by the improvement in their commercial provider contract negotiations, which decreased their medical trend modestly. Additionally, as we mentioned in June, United has offered to reduce their administrative fees by 10% for the month of July in light of the state budget. The savings from this reduction was used to further reduce the 2021 premiums. These changes brought their overall increase for 2021 down from 5.31% to 3.94%. I also want to note here that we received word last week that UC Davis has opted to not renew its contract with United Healthcare effective January 1st, 2021. We are working on a communication to the impacted United Healthcare members that will inform them of the contract termination, give them options in the next open enrollment to switch plans should they want to stay with their UC Davis health providers. Next slide, please. Western Health Advantage has also offered to reduce their 2021 administrative fees in light of the state budget. The savings from the administrative fee reduction brought the proposed 2021 rate increase down from 3.49% to 3.42%. Next slide, please. Anthem is now projecting an increase in CMS revenue due to updated claims experience and enrollment data. This brought their overall change for 2021 down from an increase of 0.06% to a decrease of 1.23%. Next slide, please. After any questions, you will have an opportunity to vote on the final 2021 premiums for HMOs and PPOs. In the following weeks, we will be communicating with members, employers, and stakeholder groups. We will work with our partners across the enterprise to prepare for open enrollment, which will begin on September 21st and end on October 16th. We will be implementing the new premiums and rate changes on January 1st, 2021. I, along with the rates team, recommend approval of the HMO and PPO premiums, and this ends my formal presentation, and I'm happy to answer any questions you may have.
Thank you, Ms. Green, for a very succinct, as usual, presentation. And thank you and all of the staff working on behalf of our members, working very hard to have the healthcare premiums as affordable as possible. So we do have a number of questions. Go to Ms. Wesley.
Hi, Ms. Green. Thank you so much for your presentation. Your dedication to this and your detail. I just really appreciated it being a new member of this, of the committee, the health committee. But for my own edification and understanding, thing happens where United Healthcare, for instance, UC Davis opts not to accept them anymore. I'd love to hear a little bit more about that, why that happens, why this specifically happened, if you know, and then also how we're able to help place those folks in United Healthcare with another provider that will have the same level of service as someplace like UC Davis does. This is very disappointing.
Yep. So I can't speak for either UC Davis or United Healthcare specifically, but my observation is that their contract negotiations have been contentious for a number of years. As I have met with both organizations over the last 8 months, they have both indicated that there was a potential rift in the relationship. Previously, they closed the panel to new members, so only folks that had already selected UC Davis as their provider assignment were able to stay. So that was a year or two ago. And then they also restructured the contract to be more capitation focused and less fee for service focused, which improved the cost of the contract. But I just believe that that relationship has been on the rocks for quite some time. The fortunate thing is we have a number of plans that have UC Davis in its network. And so those members that are impacted by this termination will be noticed which plans are available to them to select. The one that is probably the most similar from a price point standpoint is Anthem Select. And so there is a product that they're going to be able to transition to that is very similarly priced that will retain them access to the UC Davis system.
I'll just add that it was really important that we got this information before open enrollment happened, because it allows us to execute a communication plan, and make sure that that anyone who needs to be in UC Davis, and there are often really important reasons why you need to be in an academic medical center in particular, for certain kinds of conditions, for example. They will know that, and they will be able to choose different plans.
I could imagine how hard that would be for a patient to find out after the fact. So I'm really glad we're finding this out now. When you compare them on a price point with comparable plans, how do we know that whatever specialized care that people are getting from UC Davis because of that academic kind of environment, that same type of care will also be available through the other plan with the same price point, or is it the same price point but a different set of approvals for the special care that they're getting?
It's they're identical benefit designs across our flex funded plans. And so it will be the same cost sharing, the same process by which you access care at UC Davis. So it should be the same experience. It's just you're dealing with a different health plan. So you're dealing with a different call center. Yep.
Same, specialist. Okay. Thank you so much for that. I appreciate it.
You're welcome.
We have another question, but staff, when you speaking for the first time, would you identify yourself so the public can know who's speaking? Okay. Mr. Fechner.
Thank you, Mr. President. First of all, I want to start by thanking staff for all the hard work that it's taken to get to this point. I also want to say that, I'm pleased that apparently the plans heard us over the last few years and came in with a little sharper pencils than they had in the past, which is always a good sign. That being said, I'd like to make a motion that we approve the HMO and PPO rates going forward from this point. Thank you, Mr. President.
This is moved by Mr. Fechner.
Second.
Second by Ms. Taylor. Further discussion, Ms. Taylor.
Thank you. I just muted myself all over again. Thank you, Ms. Green, Mr. Molds. I really appreciate the work you guys have done on keeping these rates as low as possible. And I know we're going to be going through some additional information as we're talking today on how we can continue to keep these rates low. I'm very impressed with how you did negotiations this time to just get, rather than what we've done in the past, but use our resources to get to the rates we needed to get to. Also appreciate, given state workers are taking a pay cut, appreciate the plans that have chosen to reduce some fees, and that's helpful. And again, I echo Mr. Fechner. The plans have sharpened their pencils. It seems like we're not doing this huge rate increase, and then we tell them to sharpen their pencils, and then they finally come in with a better rate increase. But I just want to also voice that it's still above the consumer price index. So it's, it's still high for most folks. It still impacts everybody's wages. So we still must continue to do this work to keep the rates as low as possible. And then I guess I had a question on the United Health Care. So for UC Davis, so I think there's only two other plans, if I'm correct, right? That's the Anthem and the Blue Shield, I think, are the two other plans that still have UC Davis.
And the PPOs.
And the PPOs. Okay, so all of which are substantially higher than United Healthcare, is that correct?
Anthem Select is at a somewhat similar price point. So that's why I was drawing the parallel that likely if you want the same price point and the same access to UC Davis, Anthem Select is probably the logical choice for the individuals.
Okay, I'll have to have some people that I know that are in that plan. I'll have to take a look at that as we go through this. And then again, I just want to, whatever it takes, whether it's, reference pricing, I just want to encourage us to continue to talk to the plans, talk to the providers, et cetera, so that we can continue to work on pricing. And thank you guys very much for your hard work.
Absolutely.
Okay, thank you. And I just want to let the public know that if there are any members of the public who wish to make public comments, please call in to the meeting at this time, because I see I have a couple of more questions, and then we will go to public comments. So at least you will be in the queue to make your public comments when we get to that point. So with that, Mr. Rubalcaba.
Thank you. I too want to thank staff, Martha and her team for great renewal season. I think it was a good approach to have a baseline to which to start, so everybody knew that, other insurance carriers. I want to commend you for your work. I wanted to second the motion for approve the rates, but Teresa already did, so I just make a comment. Thank you very much, Mr.
Okay.
Jones.
Thank you. Let me see. I see no other comments from board members. I would just like to raise a question regarding the request to reduce the administrative fees. I recognize, based on your presentation, Ms. Green, that most of the providers have stepped up to the plate and provided a reduction. In other words, sharing the pain that we're all going through. However, Kaiser did send a letter to the board indicating the reasons why they cannot reduce their administrative overhead. I would like to get a clearer understanding that, it's not just, and I applaud the definitions or the explanations that they provided to provide the, being responsive to the pandemic of COVID-19. But other plans are also sharing the pain. So why can't Kaiser share in the pain? And if that is not possible at this point, you indicated that these costs are related to the COVID-19. So what do you plan to do going forward after we pass this pandemic environment that we're in? So is anyone there from Kaiser or Ms. Green to respond to that?
Yes, we have Cynthia Striegel, who is with Kaiser. She's on the line. I believe that our host needs to promote her to a speaker in order for her to be heard.
Cindy, you've been promoted. Go ahead and unmute your mic and your camera, please.
Good morning. Can you hear me?
Yes, we can.
And can you see me? Okay.
I don't see you, but
So
we can hear
I
you.
have, let's see. Okay, there we go. Good morning.
Yeah, now I can see
I
you.
think you guys can see me and hear me now.
Yes.
Okay. Thank you so much, President Jones. I know new technology we're all getting used to. Appreciate the question and also the comments you made about the response that we provided. We took your request, and we've received this from many, very seriously. We took time to evaluate it within our organization and understand the current situation that's happening with the pandemic, but also with our individual approach to each renewal that we have with our customers. So I wanted to share two perspectives. The first will be something that wasn't included in our letter that is not related directly to the pandemic, but our approach to your renewal that played a part in that decision, as well as spend a little bit of time just articulating some of what was in that letter. I'll try to keep my opening remarks short to allow for you guys to have some questions, but I welcome a dialogue wherever you may want to take it. So this year, as Marta said in her presentation, they took a very different approach to the renewal season than we've seen in quite some time from CalPERS. We met early with the CalPERS staff. We met often with them, and they were really very direct and set very clear expectations with us early on that they wanted our very best, most aggressive rate from the beginning. And so in our February submission, we looked at the data that we had available, which was a bit earlier than we go to market. Usually our data is available in early April, but to fit your timeline, we submitted our best rate that we could with the data that we had at the very end of February, very first, second day of March. And we used the most up-to-date rates that we had at the time. And so with your request, we had a chance, the ability to look at the additional data that we needed, that we would have gotten to complete that renewal. And we saw that utilization, the additional material that we had available to us, put upward pressure on your renewal. So we had some really tough conversations with Marta and her team and Dawn and others about what that utilization showed and what impact it could have on the renewal, as well as the very early indications of COVID just starting. We hadn't quite yet shut down at that point, but very soon after the data became available, we were on stay at home, and we were seeing the first wave of the surge of dynamics. So we had some really challenging conversations. We looked deeply with that data with Marta and her team. We talked extensively about what we were seeing with COVID at that time. And as a result of those discussions, we maintained the rates that we had already provided and did not increase them for either the additional view of that utilization, which had the upward pressure, or the potential impact of COVID, because it was pretty early in the process and unclear about what was going to happen, even though we were beginning to be deeply felt by those. So that's one piece that it was a new approach for us this year with Marta and her team. The second part was much outlined in the response that we provided. The unique approach or structure for Kaiser is that we're providing both the care and the coverage. So we're not just processing claims, or we're not just processing encounters that happen in other hospitals and medical providers. We're actually providing the care, as you all know. We're an integrated nonprofit organization. We have close to 40 hospitals, a little over 700 medical offices, and we're personally engaged in every aspect of managing the pandemic, from screening and testing and treating and prescribing and hospitalizing and the recovery associated with the long-term effects of those that are impacted. We've treated tens of thousands of patients for COVID, including intensive inpatient treatment for well over 2,500. people with the disease, thankfully not 25,000. And we're particularly focused on the safety of our employees while we're doing that. So as a result of that, we've also procured millions of PPE, equipment, supplies, even through a worldwide scarcity. So the cost of those items can be challenging during the times of pandemic. Our organization is also deeply engaged in the multiple efforts to help communities prepare for and manage through this crisis. We've worked with local, state, and cities and counties to prepare for the surge. We've set up processes to avoid charging individual members for any treatment that they may need in hopes of not delaying those services and reducing the potential spread. In the coming months, we pose significant risk to healthcare organizations of any size and variety. And like others, we are working hard to adjust to the immediate and potentially long-term economic disruptions that affect our organization and our patients, our customers, and communities. There is still a lot of uncertainty as it relates to COVID around utilization, including testing, for not only the remainder of 2020, but 2021, with shelter-in-place mandates lifting, and in light of yesterday's governor's announcement, and the population adjusting to a new normal, we will still need to be prepared as a delivery system as possible surges continue until there's a vaccine. We continue to source and manage our personal protective equipment. We have also seen in the news the last several days to weeks the uptick in cases, and that people have grown a bit weary of the restrictions and have tried to go back to a pre-COVID activity. We also anticipate a much harder flu season this fall, as it will coincide with COVID-19, and it will hit at the same time. So Kaiser Permanente has incurred and will continue to incur additional costs for surge preparedness, personal protective supplies, testing, pharmacy, and outside claims. While there are some offsetting costs, we are still forecasting a quite uncertainty. And I'll go back to the beginning, which is the uniqueness of our model is that we're both able to see the impact on the hospital and the delivery side, as well on the health plan and pharmacy side. So available for any questions.
Thank you for the explanation, and I recognize that it is kind of unwarranted or impossible to challenge the impact of COVID-19. So we will give you that, but just remember, when we establish this new normal, we want you back at the table to be sure that you're participating in reducing our cost to our members. So with that, Ms. Ross, please.
Thank you.
Yes.
Okay.
Okay. And my question wasn't Kaiser specific, but thank you, Ms. Drago, for that
Thank you.
information. And also just wanted to thank Marta for that wonderful explanation. And my question just was, as we get into the discussion, kind of for Dawn, big picture, when we talk about the competition and cost savings, I was just wondering what the dynamic that's been going on between UC Davis and United, how that plays into the competition, because my understanding of the UC Davis model is it's very provider driven, and how that factors into the dynamic of the decreasing competition out there. And it definitely, without wanting to project what's really going on, I'm very curious how that dynamic of that model at UC Davis plays into the competition in the big picture for healthcare costs.
Sure. Don Molds, Chief Health Director, and sorry to not introduce myself the first time.
No problem.
So that's a great question. And the short answer, and I'll touch on that a little bit both in my presentation later on today, and happy to kind of go into it more. But in a nutshell, as we look at areas and assess whether there's high competition or low competition, one of the considerations is whether the providers in the area are high cost for secondary reasons, and academic medical centers fall into that category for many reasons. And when that happens, they tend to put less downward pressure on rates that are being offered by other provider groups. So you start to kind of exclude them as potential competitors who are going to help create an environment that brings down costs. So it's a challenge. And if you have a bunch of UC Davises, not single out UC Davis in particular, but if you have a bunch of higher cost providers competing with each other, you don't have that downward pressure on price, and that becomes a problem.
Okay, Ms. Ross?
Yeah, thank you very much. That kind of what I figured was going on, and I just appreciate that, how it integrates in with our strategies.
Okay.
I'll just add, when we look at the heat map this afternoon, you'll notice that Sacramento used to be lower cost, and now it's higher cost. And one of the reasons is that we don't have that kind of downward pressure. You see the same thing in the Bay Area.
Okay, Mr. Miller.
Yeah, thank you. I just also again want to share how impressed and I am with the team's work. Dr. Molds, Marta, I've been involved in this as a stakeholder and a spectator for decades, and just the strides we've made, CalPERS, in terms of our ability to really get under the hood and start to finally. There's still some kabuki theater and black box stuff going on that we don't have all the information and answers, but it's just evolved so much, and these last few rounds have been very encouraging to me. The thing I still continue to worry about is the pendulum has gone back and forth over the years, more competition, less competition, managed competition, all these different theories, and the theory and the practice end up being two different things. And we'll probably talk more later this afternoon about the concern that our approaches and the reality of the offerings that are out there in the various areas of the state, particularly in rural areas and hard to serve areas, is the folks with the most acuity, often folks with most tenure among the active or our retirees, continue to be kind of this adverse selection suite where we see with the PPOs, where the costs are just out of hand. And at the same time, this movement of providers to try to, get people into the higher margin programs, the lower cost programs, expanding things like the Trio, which that's that seesaw. On one hand, there are benefits, but the kind of adverse impact on the folks who can least afford it and have the greatest needs as we move those younger, healthier, typically younger, healthier lives into these more competitive products for their segment of the people we serve. I just think that is going to be one of the biggest challenges we face that becomes more acute even than the average nominal cost of an increase spread across the board at under 5% versus the big hits that people who can least afford to take it, especially when public servants, in many cases, certainly in state government professional, are seriously underpaid versus their counterparts. They don't have the kind of nest eggs and resources in retirement that their counterparts do, and now they're taking even more hits and rollbacks on pay that's already way under market. So I think we'll have to just count on our team to continue to do the fine work and continue to deliver the kind of results year after year that get us closer and closer to an optimal situation. Thank you.
Okay, Ms. Oliveris.
Thank you. This is for Ms. Striegel. So, Ms. Striegel, I wanted to understand what Kaiser's anticipated surplus is for 2020.
Hi, good morning. Good morning. It's still morning. Our anticipated surplus overall as an organization for 2020?
Yes.
Okay, I just wanted to make sure you can hear me. So our financials for the year, what my honest answer to that is, it is unclear what the rest of 2020 is going to look like. We are expecting utilization to meet and exceed where we were last year as we get through later in this year. So we start to get a little bit back to a new normal, a little bit back to doing some of those procedures that we have paused and delayed out of cautiousness for our members. We are seeing individual encounters with our members. So the overall engagement with our members getting back up to pre-COVID levels, but in a different modality. So more virtual, more videos, more telephone appointments, and less in person in order to maintain the safety. Our first two quarters are always bigger than our last two quarters. They level off towards the third and fourth quarter. Very difficult to answer that question because we do not know what the next 6 months of the year looks like, given especially the latest surge that we're having in both the Bay Area and in Los Angeles. Our objective each year is to strive for the range between the 4 and the 6% margin that we have, that we then use to reinvest in the system to build technology capabilities, facility updates, et cetera. That is still our objective, but it is uncertain how the year will end.
Thank you. What do your 2020 interim financials show?
So our first quarter is out, and it shows losses, but it's losses really related to the investment market. So everyone saw the investment financials drop for first quarter. Ours was no different. Second quarter is not out yet. I haven't seen it. I suspect that it will show a positive result as it has in previous years. And a good portion of that is there is quite a bit of expenses for COVID-related services that will hit in third and fourth quarter that are not reflected in second quarter, but our second quarter financials have not come out yet.
Can you tell me what the 2019 surplus was?
Give me one moment, if you would.
Sure, I have that it was 7.4 billion, but I would just want to clarify that with you. And while you're looking,
Correct.
could you look up your cash reserves too?
Yeah, so 7.4 billion for 2019 was a 3.2% margin. So our focus of being between 4 and 6% in order to fund our integrated delivery system was our target, and we ended with a margin of 3.2% for 2019.
And your cash reserves?
I don't have that on me right now.
Okay, that's in the financial statements. So I understand Kaiser is well in excess of its cash reserves. So there's a minimum amount of cash reserves that's required. I understand that Kaiser had about, at one point, 1,600% of that. So very significant cash reserves. And so I'd like to get that number too, please.
Sure.
I'd like to get your minimum required cash reserves and your current cash reserves.
Okay. And I thank you. I've written those down. What I'll say about the perspective, so on our balance sheet, so I hear often in the market a conversation about our cash reserves. Our balance sheet, and when we look at last year, reflects what it takes to run an integrated delivery system our size. And given that dynamic, we find that our sheet is appropriately strong. We need to make sure that we maintain on hand the cash levels so that we can actually fund a delivery system. And our balance sheet and our cash supports both our long-term debt, which is around our hospitals and medical facilities, as well as our long-term investment responsibilities, which is predominantly around our pension funding.
Are you aware that Anthem had its tax exempt status revoked for having too much in excess cash reserves?
That was one of the reasons. Referring to Blue Shield's nonprofit tax? Yes, I'm aware of their change in their nonprofit status. I don't know their details.
Okay, I think that is an important thing to look at there. And I wanted to touch on your comments regarding COVID and providing PPE for practitioners and ensuring a safe work environment for practitioners. It's been my understanding at Kaiser West LA and Kaiser Sunset that there has not been adequate PPE for physicians and for nurses and other medical personnel. And in fact, personnel that I know that work in the COVID units can't get tested unless they are symptomatic. And as we know with COVID, you can go 14 days or even longer with being asymptomatic. So we're seeing a sharp increase. I implore Kaiser to allow free testing for all its personnel, free COVID testing.
So a couple thoughts around that. We don't disagree with the need for there to be significant testing, especially for healthcare providers. We've prioritized symptomatic folks. We've prioritized those that are in the hospital getting procedures, either pre-surgery or for other reasons, and we've prioritized first responders. We've worked very diligently on expanding our testing capabilities. We are currently between 16 and 18,000 tests a day, striving towards 20,000. We've built new labs, we've ordered equipment, we have additional equipment being built as we speak in order to increase our volume even more. In terms of, I'm going to address in two ways. In terms of our own staff and our own employees, there is significant resources on the ground at each one of our medical offices and hospitals for employees to engage with leadership in any area that they're concerned if they feel that their safety is at risk. And so I encourage them to elevate those concerns to their managers or the leaders above them. It is something that each hospital and medical office talks about every single day and engages with their employees. So I'm disheartened to hear that that's how they're feeling, and I encourage them to raise it. It is not our perspective that employees should not be tested and feel safe coming to work. When it applies to our members and not just our employees, we also support members who have a need to get tested that are not able to do so within Kaiser because of our limited capabilities and our prioritizing of those items that I listed earlier, that they are able to seek testing and receive reimbursement from Kaiser Permanente for doing so outside of our network.
I'd like to clarify, this is not about employee sentiment. This is Kaiser policy. Employees working the COVID ICU units cannot get tested unless they are symptomatic. That is a public health danger. That is Kaiser policy right now. And no employee should have to worry about their job by raising this matter. That should be standard policy that anyone working the COVID unit should be able to be tested. They should not have to be symptomatic. I'd like to see a change in that policy.
I have noted your request. I cannot share that that is against our policy. I don't know that firsthand. It is not something that I can agree or disagree with, but I will take back your comments and requests around the employees that are working in those facilities.
Yeah, I have firsthand knowledge, so I'm very aware of the policy. Thank you.
Okay, Ms. Wesley.
Thank you, Ms. Olivares, for your comments, because I learned a little bit more about Kaiser and I appreciated that. I have a comment that's really not a question, but it's relative to Kaiser. I know that Kaiser's concerned that they can't really say what's going to happen with COVID. Nobody else is, and they've been able to do better. And that Kaiser, I understand, considers itself uniquely situated as both a caregiver and a plan. But one thing I wanted to also mention is that you are also uniquely situated as a business who requires patients to sign binding arbitration agreements. So they cannot sue for medical malpractice or medical errors. And so denying them their day in court will also affect your bottom line. And I would think that with that savings, you could do better for CalPERS. That was my comment.
Okay, thank you. Ms. Brown. Can't hear you, Ms. Brown.
Sorry. How about now? Can you hear me?
Yes, yes, we
Great,
can.
thank you. I too want to thank Ms. Olivares for her comments. I wasn't aware of the Kaiser testing policy, but maybe we'll find out that maybe they're different in different places, but I hope that's not correct. I also appreciate Ms. Olivares bringing to our attention the cash reserves. Again, it's another way of, hiding profits. I know that in CalPERS, when we look at our healthcare systems, we have certain requirements for cash reserves, and then when they're over, we give that money back. And so I'm hoping that we can find out more about Kaiser's cash reserves. But I have a specific question for Marta, since I know she'd like more screen time. Going back to the HMO rates, attachment 1, page 1 of 3. When we talked last month in closed session, we talked about what was going on with the health net rates and why those were going up because they have a Saludimas, because they have a specific group of patients, kind of unique down here in Southern California. But I want to talk about Anthem Traditional because that is going up a huge amount. And especially compared to Anthem Select. And so just could you explain for me and for our members why that huge increase?
Yep. This really has to do with the issue that Mr. Miller brought up about risk fragmentation and adverse selection. So the population in Anthem Traditional, which is exceedingly small, is also some of the highest acuity population we have in the entire portfolio. And Anthem last year, we estimate lost about $12 to $13 million on that product due to high cost claims that hit on that product. And so this is the natural result of risk fragmentation and adverse selection. You have those with higher healthcare needs consolidating in plans, then the membership shrinks because those plans become unaffordable. And as it shrinks, then the risk profile of that membership continues to increase and they enter what's called a death spiral. And that's what's happening in Anthem Traditional currently. The membership is just some of the sickest in our population.
And do we have...
I'll just add that Marta is doing the risk mitigation discussion later on this afternoon is about exactly this subject. So we'll be going into quite a bit of detail both about the problem and about proposed solutions. But it's something that we certainly noticed in our focus on.
Thank you. I appreciate that because we need to hopefully try and find a solution, because with this 9% increase, we're going to have that again. People are going to say it's too expensive, I need to jump. And then we have only the sickest people again. And we see the same thing with PERS Care too. Is that correct?
Yes, and Blue Shield Access Plus. All three of those products are very fragmented.
All right, thank you.
Okay. Ms. Taylor.
Yes, thank you, Mr. Jones. I also want to give Stacy some kudos there for your comments. Specifically, Cindy, Ms. Friedel, I guess the cash reserves is what piqued my interest. It didn't, and I'm sure that our folks have looked into all of this and heard these explanations about, the necessity of keeping the cash reserves. I think it would be interesting to have you come back with the cash reserves, because given that, I mean, even administrative fees are small, we have to share in the pain. Workers are always the ones that have to share in the pain. We're asking our health plans this time, and I understand COVID is an issue, but we're asking our health plans, as we take a 10% pay cut as state employees, and other, localities will probably either have to take cuts or layoffs or whatever, that our health plans participate in this. So for Kaiser not to give any kind of administrative leeway here, and I'm not saying that your rates are high, your rate increase is high, but it's still something that I think we need to seriously think about in terms of what other venues you have. Your business plan is different than the rest of our insurance providers. So is there something else we can talk about further in the coming year that we can take into consideration for you to continue to lower your rates? Because I think not even giving a 1% reduction for CalPERS during this time frame when all the workers are taking huge pay cuts seems a little off message and a little bit tone deaf right now. And I don't know if you want to make a comment on that or not.
Can I suggest that there are a number of questions that board members have raised surrounding the financials of Kaiser. So I'm going to ask the chair of the Health Benefits Committee, Mr. Fechner, to get those questions and schedule some kind of meeting going forward so that the board can get an overview, a response to those questions. So Mr. Fechner, if you could take that on, I appreciate it.
Will do. Thank you, sir.
Okay, okay, Ms. Middleton and Mr. Jacobs, if you're not on beyond, because I think this question is going to be directed to you. Ms. Middleton.
Thank you, Mr. President. And first, I want to thank all of my colleagues, and I'm not going to repeat all of your excellent comments and questions that you have raised. But this is just a procedural question to get it on the record. Many of us are members of CalPERS, and we are voting on health plan rates that will have a personal effect. But as I understand it, we are not legally conflicted in taking that vote. Is that correct, Mr. Jacobs?
Yes, Trustee Middleton, that's a very good question. It shows a careful, really being attuned to this potential issue. But yeah, because this issue applies so broadly to essentially millions of beneficiaries, including yourself, this is an exception to the rules that might otherwise apply regarding conflicts of interest that would perhaps otherwise prevent you from voting on something like that.
Thank you, sir.
Okay, thank you.
You're welcome.
Okay, I see no further questions from board members. So, Mr. Fox, we'll now go to public comment. And I did say Mr. Fox, Ms. Frost. Thank you. Okay.
Thank you, Mr. Chair. We have a total of 4 callers on the line. First, we have Mr. Tim Behrens from California State Retirees.
Okay, and I want to remind the public members that we'll provide you 3 minutes for your comments.
Good morning, President Jones, members of the board. Tim Behrens, President of the California State Retirees. I want to echo the board members in thanking Don and Martha Green and their team for doing a great job, actually doing some things that have never been done before on behalf of the stakeholders. I want to highlight United Healthcare reduced from 5.31 to 3.94. And even Western Health went down 0.37%. Unfortunately, the PPO rates continue to be high. 7.91, 7.14, and 12.32. And I would echo a couple of the active employees on the board and concern on behalf of those active employees, state and public employees that are taking a hit now, either a furlough day or a reduction in salary. I hope we can continue to, as Mr. Fechner says, sharpen the pencil. And on behalf of our members, I want to thank you for your outstanding work on behalf of the stakeholders of CalPERS.
Good. Thank you, Ms. Barron. Mr. Fox.
Mr. Chair, the next caller is also from California State Retirees, Mr. Larry Woodson.
Good morning, Larry Woodson, California State Retirees. Thank you, Mr. Chairman, for the opportunity to comment. I'd also like to thank the health team for their hard work and with their new approach this year on using their own CalPERS data to negotiate rates. I'd also like to point out that Don Bowles and Martha Green are first timers at this negotiation process in CalPERS, and under very difficult circumstances, I think did overall a very fine job. So thank you. I'd also like to say I'm glad to see that United Healthcare and CalPERS were able to lower rates. $10 a month is not a lot, but it's lower. It's in the right direction, and I appreciate that. I'm very concerned about the termination of the UC Davis United Healthcare contract. I'm assuming that the replacement contract, well, first of all, it wasn't clear in the presentation that if you're just talking about the basic plan or also the Medicare Advantage plan, because if, you know, United Healthcare has always said any provider that takes Medicare will take United Healthcare Medicare Advantage. So it would be nice to know what if it's both of those plans are being terminated, and also how many impacted members are we talking about? And lastly, on that point, I thought the Blue Shield Trio had come into Sacramento and perhaps had UC Davis. I may have been mistaken on that. So, but and then I'm also, as Tim said, concerned about the PPO plans. They're basically doubling the rate increase over the HMO plans, and I think I have an idea as to why, but it would be nice to see those a little more in line with the HMO rates. And then finally on Kaiser, you know, I mean, Kaiser is a nonprofit, and the kind of cash reserves that were pointed out, and also, you know, they had a $3 billion quarterly profit recently. That rivals United Healthcare's profit, quarterly profit. So I'm a little disappointed that they weren't able to at least tweak theirs down a bit. Anyway, I'd like to thank the board for their probing comments, and I'll end it there.
Thank you for your comments. Mr. Fox. Mr. Fox?
Yes, Mr. Chairman, or excuse me, Mr. President, we have a caller from SEIU, Tanya Whipple.
Thank you.
Hello and good morning. My name is Tanya Whipple. I work at Chuckawalla Valley State Prison. I am a correctional case records analyst. As an analyst, I am responsible for auditing inmates' files when they are in prison. This includes making sure their commitment is correct, as well as their release dates when they parole. As many of you are aware, CDCR is releasing 8,000 to 10,000 inmates early due to COVID-19 this month. Every one of those files have to be audited by a case records analyst before they can parole. I have worked for CDCR for 22 years. When I first started back in 1997, I was a single mother, excited and so thankful for my job and its wonderful benefits. At the time, with me and just my son, I paid zero out of my check for my HMO medical insurance. It was wonderful. I paid zero, had excellent coverage. No problems at all finding gynecologists or specialists when they were needed. My check at the time was only roughly $1,600 a month, or about $19,000 annually. Fast forward 22 years. Now married, 3 kids, 5 promotions later. My insurance is now a family plan. Now I pay $781 a month for my plan. My check now roughly $2,800 a month, or $34,000 annually. Now, take into consideration also the lack of doctors, not only in or close to my residence due to I'm a very rural area, but also doctors do not want to take my HMO insurance. I cannot afford to go PPO. There's no way. It seems over the past 22 years, my insurance has went from the best, awesome, wonderful insurance to the worst. It is hard to find gynecologists or specialists when needed. If you do have one at the time, if you do happen to find one that takes it, a lot of the times they aren't taking new patients. Please, I urge you to find ways to control rising costs and help those of us who live in rural areas to get better access to care. Thank you guys so much for your time. Tanya.
Okay, thank you for your comments, and I'm sure staff is looking into the very issues that you raised. Next speaker, Mr. Fox.
Yes, Mr. President, I'm going to try to connect Deborah Holland from SEIU.
Hello, am I on?
Yes.
Okay. Hi, my name is Deborah Holland. I work for CDCR, Ironwood State Prison, and I've been there almost 10 years. I am very disappointed in how our healthcare premiums keep going up while pay cuts to our salaries just started this month. I'm paying $597 a month for healthcare for me and my spouse. I am the sole provider in my household, and we do need healthcare insurance. Paying $597 a month for coverage out of pocket is a good chunk of money. It has placed a huge burden on my shoulders, just thinking that the premiums might go up even more. With the pay cuts with no raises, and we are only halfway through the year, it is really starting to stress me out. I've been with the state going on 10 years, and I keep seeing the premiums go up. I can say I see how our members with SEIU are being affected. Single parents, even married couples with children, and now we are going to lose 10% of our pay. I drive 125 miles one way to work, and with the price of gas, no raise, and insurance premiums going up, it will hit me hard. So I can only imagine for the members that don't make as much as I do. I'm a nurse, so I do make good money, but with all the cuts, it's gonna hurt. Please do everything you can to keep premiums from going up and continue to offer us quality health care. Thank you, Deborah Holland.
Okay, thank you, and we certainly hear you. Next, Mr. Fox.
Mr. President, we have one last caller on this subject, Sarah Zimmerman from SEIU 1000.
Okay.
Thank you. Thank you, board members, and thank you, staff, for working on negotiating in these difficult, strange times. I just had a technical question to understand a little bit more when you talk about the lowering of administrative fees. I know with the Western Health Advantage, it was 3.49 to 3.42, and there was some reduction of United Healthcare. Is it possible just to understand exactly what that means in dollar amounts in terms of the overall plan cost and the impact on the individual?
Continue your comments. We will have, you can reach out to staff to have a greater explanation of that. Do you have any
I just
further
thought before
comments?
the board votes, it would be helpful to understand in dollar amounts what the impact is, if possible.
Yeah, I think that question that goes better to have someone meet with you to walk you through that process. Okay, do you have any further comments?
No, I do not.
Okay, thank you for your comments. Is that it, Mr. Fox?
That concludes public comment, Mr. President.
Okay, so we have a motion on the floor by Mr. Fechner and second by Ms. Taylor. And this is to approve the 2021 Health Maintenance Organization rates and approval of the 2021 Preferred Provider Organization rates. Mrs. Hopper, please.
Margaret Brown. Aye. Rob Fechner.
Aye.
Frank Ruffino for Fiona Ma.
Aye.
Lisa Middleton.
Aye.
David Miller.
Aye.
Stacy Oliveris.
Abstain.
Irena Ortega.
Aye.
Jason Perez.
Aye.
Ramon Rubacava.
Aye.
Teresa Taylor.
Aye.
Shonda Wesley.
Aye.
Karen Greenross from Betty E.
Aye.
Mr. President, we have 11 ayes and 1 abstention from Stacy Oliveris.
Okay, thank you very much, Ms. Hopper. So the item passes. Now we will move to the next item on the agenda, association plan rates. Ms. Green.